So we're going to shift a little and talk a little bit on the lighter side. So we're going to move away from the clinical to policy side. And I'm going to speak about understanding the role of policy in improving obesity treatment and kind of go over how we do it at the American Heart Association. So Dr. Neeland already introduced me. My name is Melanie Phelps. I am the Senior Advocacy Advisor for Health System Transformation. I have over 30 years of health policy and advocacy experience. My current focus is not obesity. It's actually health system transformation, but somebody at the Heart Association saw the Institute for Value-Based Medicine and said, I don't know what that is. So they tapped me to do it. Anyway, so I'm going to talk about policy, and again, I'm going to cover how the American Heart Association does it. So let me move on here. All right, first some background of, a little bit closer, is that better? Sorry, guys. So some background on the American Heart Association. Just out of curiosity, how many of you have heard of the American Heart Association? Okay, most of you, our brand recognition is quite high, and we've been around for quite a long time. And in fact, we're celebrating 100 years of fighting heart disease and stroke, striving to save and improve lives. So you might have heard me use the word stroke, so another question. How many of you know that the American Stroke Association is part of the American Heart Association? Okay, well, I didn't know that until I started working at the Heart Association about 2.5 years ago. Let's see, our mission is to be a relentless force for a world of longer, healthier lives, and our vision is improving health and hope for everyone, everywhere. We are the nation's oldest and largest voluntary organization. We've invested more than $5 billion in research, which makes us the largest not-for-profit funding source for cardiovascular and cardiocerebral and cerebrovascular disease research next to the federal government. We're based in Dallas, Texas. We have a significant presence in the United States and globally. We actually have about 3,000 employees globally, but most of those are, of course, based in the United States. And this number surprises me every time I utter it, but we have close to 40 million volunteers and supporters. So it's no wonder that so many of you recognized who we are. So these are essentially the foundational pillars of the American Heart Association. We basically start with the science. The Heart Association and the Stroke Association, we publish medical guidelines and scientific statements on various cardiovascular disease and stroke topics. Our volunteers, many of who are in this room, and other healthcare professionals write the statements. They're supported by scientific studies, published in recognized journals, and have a very rigorous review and approval process. If anyone's been on any of our writing teams, you know it can be somewhat arduous. Our scientific statements generally include a review of the data available on a specific subject, an evaluation of its relationship to overall cardiovascular disease science, and usually a position on the basis of the evaluation, which is key to everything else that we do. Okay, so next is our quality of care pillar. Our Quality Outcomes Research and Analysis, or CORA department, converts the evidence-based guidelines into actionable quality improvement and registry tools to assist with implementation and practice. Then we have Get With the Guidelines. How many of you are familiar with our Get With the Guidelines? Okay, good number of you. They provide hospital teams with the most up-to-date research-based clinical guidelines for heart and stroke care. And since 2001, our programs have helped more than 11 million patients. We have Mission Lifeline and Target Strokes, which help EMS and hospital teams remove obstacles to promote heart attack and stroke. We have certification programs and recognition programs such as Target BP, which we do with the AMA, and then Target 2 type diabetes, and then we also have check, change, and control cholesterol. Our next pillar are educational and community resources. This would include things like CPR and AED training. We have community impact funds to strengthen community efforts to address the social determinants of health. AHA was a Million Hearts collaborator. We recently launched the National Hypertension Control Initiative, which is an evidence-based community program with the goal to reduce high blood pressure in under-resourced neighborhoods. Another example here would be our CEO Roundtable, where we provide resources to help large employers improve the health and well-being of their employees and their dependents. And then there's the policy and advocacy pillar. So policy research, we use the evidence and we develop evidence-based policy statements to better ensure that policies that guide our advocacy efforts are consistent with the evidence. And then advocacy. And through federal, state, and even some local efforts, AHA staff and volunteers seek to enact evidence-based public policy solutions to improve health, and that would including with support from our vast grassroots network called You're the Cure. Curious if there are any You're the Cure volunteers in here. We did this really cool fly-in 2 weeks ago on Capitol Hill to support the access to AED and the Hearts Act. It was a lot of fun. If you haven't done one at the state level or the federal level, I highly recommend it. It's pretty fun. Of course, then I'm a policy wonk, so I kind of like that kind of stuff. All right, so, as with all nonprofits, there is a problem that we want to address, right? And ours, of course, is a whopper. Heart disease is the leading cause of mortality and morbidity in the US and globally. And stroke is among the top 5 causes of mortality in the US and ranks second globally. There continues to be significant racial, ethnic, geographic, and age disparities in heart disease and stroke that need to be understood and addressed. And in the past few years, we have seen trends worsen. That's not good, and costs continue to rise. And this is despite all the significant advancements in science, medicine, and technology to improve cardiovascular and cerebrovascular care and outcomes across the care continuum and lifespan. Earlier this week, the American Heart Association released 2 presidential advisories warning that by 2050, more than 184 million people, exceeding 61% of the US population, are likely to have some type of cardiovascular disease. And total cardiovascular disease costs are expected to triple to 1.3 trillion with a T. And that would be driven by increases in high blood pressure, diabetes, and obesity. So let's talk about obesity. Not too much, since we've already covered it a lot, but obesity is the leading contributor to cardiovascular risk factors. It also leads to the development of cardiovascular disease and cardiovascular disease mortality independently of other cardiovascular risk factors. It's caused by a complex interplay of biological and sociological determinants. And it is also, as we know, continuing to increase in the US. And as already been noted, it's on the rise among children and adolescents, and almost 1 in 5, so just under 20%, have obesity. And then among adults 20 and older, the age-adjusted prevalence is just under 42%. Between 1990 and 2020, the rates of cardiovascular-related obesity mortality tripled, with Black Americans and American Indian, Alaskan Native individuals suffering the greatest increase. So as such, it's a great interest to the AHA, and we've contributed to the scientific literature. You've already seen this article on CKM syndrome a couple times today, so we're just going to buzz past that. And just 2 weeks ago, and Dr. Nealon's already covered this, we published the implementation of obesity science into clinical practice. So that is just another example of some work that we're doing in this area. Okay, so I mentioned that we start with the evidence, and once we have the evidence-based, how do we encourage its use in practice? The evidence supports overarching policies, which gives us direction that guide our different activities. So we provide resources to support translation of the evidence into practice through our quality outcomes research and analysis and related work. Again, that's like get with the guidelines, the certifications, and the recognition programs. We also develop the programs and resources to educate and provide support for prevention and health improvement, such as CPR training and community impact funds. We have things like Life's Essential 8, which also made its way into one of the previous presentations. We develop policy statements based on the evidence, which inform our public policy advocacy strategy. So for the next few minutes, we're going to focus on the public policy and advocacy pillar. Not all organizations insist on having the evidence base behind their policy positions, but we think that it's critical that where we actually spend our scarce resources will have the desired outcome. And we believe it helps build our credibility and trust in our brand. So we feel that that's a very important thing that we continue to adhere to. So public policy and advocacy are important, and they go hand in hand. To get a public policy enacted, you need advocacy. It doesn't happen on its own. And advocacy requires direction, which is provided by the policy. So what do we mean by policy? Well, it's a pretty broad term. So according to Oxford Dictionary, it's a course of or principle of action adopted or proposed by a government, a party, a business, or an individual. Merriam-Webster defines it as an overall plan, a principle, or guidance. And I'll throw out a health-related one from the CDC. They say it's a law, a regulation, a procedure, administrative action, an incentive or voluntary practice of government and other institutions. And so those are some definitions. Now, it's important to know that policies can have the force and effect of law, or they can be just guidance. They can be public, or they can be private. Either way, policies are designed to effectuate a desired outcome or an action. So next, we're going to talk about some public policy levers, and here are just some examples. Federal and state legislation, such as the passage of the Affordable Care Act or the expansion of Medicaid in the states. Federal and state regulation or rulemaking, and I'm going to talk about the new added sugar standards that were recently enacted or promulgated by the USDA for school meals. So that was a recent and a very good win for the Heart Association and all the partners that worked with us, but we're not done yet there. There are local ordinances like those prohibiting smoking in public places. Some financial levers are available, which include taxes, like taxing tobacco products, or how about sugar-sweetened beverages, or sugar-sweetened infant formula. Subsidies and grants, such as the HEARTS Act and the Access to AEDs Act, which would provide funding to schools to apply for AEDs and CPR training and AED maintenance and emergency response plans. Agency budgets is another example of a financial lever, and Some examples are ensuring funding for things like public health infrastructure, or for the CDC, or for funds for research, or for enforcement of certain policies. There's another one called coverage determinations, so like national or local coverage determinations for Medicare to cover certain things like cardiac rehab. There are other levers like waivers, like the 1915 Medicaid waiver and the 1115 demonstration waiver to finance, to test new or existing approaches to care delivery and payment. Pilots is another example of a policy lever, and such as new care and payment models, such as those offered through CMMI. And quality measures is another. So what about incorporating obesity quality and performance measures and incentivize clinicians, health systems, and health plans to do obesity assessment and treatment? What gets measured matters. So another one. Anyway, all of these, this is not an exclusive list, all of these are designed to effectuate a desired outcome or action. So as I mentioned at AHA, we start with the evidence and we create an overarching policy position. And with respect to obesity, the position is we support equitable access to all evidence-based treatments, options for obesity, including lifestyle modifications through dietary intervention, physical activity, and behavior modification, pharmacological treatment, and bariatric surgery. From there, we look at potential public policy options or levers. We then weigh the feasibility of the options or the levers. And that's going to entail a number of factors that need to be weighed, such as resources, like staff expertise, support levels from other groups, and policymakers, et cetera. We then deploy our advocacy resources, whether it's lobbyists, regulatory staff, grassroots volunteers, marketing communications, et cetera. As new evidence emerges, we refine those policies, and the cycle repeats. So, given the serious health consequences of obesity, once it develops, we support robust policy and system changes that promote primordial and primary prevention of obesity and other cardiovascular risk factors, and support for people, family, and communities that in promoting health factors and healthy living. Oops, sorry, I am one behind. We also support secondary prevention measures, such as procedures that detect and treat preclinical pathological changes and thereby control condition progression. So screening procedures are often the first step, leading to early interventions that are more cost-effective than intervening once symptoms appear. And once the condition has developed and has been treated in its acute clinical phase, tertiary prevention seeks to lessen the impact caused by the condition on the patient's function, longevity, and quality of life. So, for example, the primary form of treatment for obesity remains lifestyle modification through dietary intervention, physical activity, and behavior modification. So our policies would basically adjust to reflect the evolving evidence. And so they're constantly being updated and modified. All right, that said, while we have numerous policies related to obesity, obesity alone, we have numerous other policies on other issues, but given our limited advocacy resources, we have to prioritize where we deploy our limited resources. And so our current areas of legislative and regulatory focus are at the federal level. I'm on the federal advocacy team, so I'm going to highlight those. Research funding for the NIH, care delivery, such as access to affordable and adequate insurance coverage, robust cardiac emergency response plans, access to equitable digital health and health system transformation. We do an awful lot of work on nutrition security. That is a huge area of focus. Tobacco control, prevention, and cessation is also another major area of focus for us. Physical activity is another, and nonprofit and mission-aligned business interest. So policies that incentivize charitable giving, we have to remain viable, so that's another area. Frequently, we work in coalitions to amplify our voice. Now, we have similar focus areas at the state level, but since I'm on the federal advocacy team, I'm more familiar with them, so that's the examples that you got. So given the size and the scope of the American Heart Association, it's really difficult to provide a comprehensive overview of all our related activities, but I did want to focus on two issues. The first, or two initiatives. The first is our recently launched Food is Medicine initiative, which we've recently branded Healthcare by Food, which seeks to build the evidence base needed to show clinical and cost effectiveness, so patients with acute or chronic disease or with risk factors for disease can access cost-effective food as medicine programs as a covered benefit through public and private health insurance. This initiative also has resources for policy development and advocacy. So it's a pretty significant undertaking that is currently well underway. Also mentioned earlier is Life's Essential 8. It used to be our Life's Simple 7, but we recently added sleep, so now it's Life's Essential 8. This falls under community education and focuses on the 4 health behaviors and 4 health factors to promote better cardiovascular health and lower the risk for heart disease, stroke, and other major health outcomes. So this is the 4 health behaviors are eat better, be more active, quit tobacco, and get healthy sleep. And the 4 health factors are manage weight, control cholesterol, manage blood sugar, and manage blood pressure. So getting back to the role of policy in improving obesity treatment, or anything else for that matter, it is critical and essential. Without policy to guide us, there isn't direction on what to work on or to act on. Evidence is only evidence if we don't derive policy positions from that evidence to translate into practice through things like the development of clinical guidelines and quality programs, through education and community resources, and the development of public policy options and levers, and then advocacy. It all works together to improve obesity treatment. At the end of the day, it is really policy and the actions that emanate from those policies that help effectuate needed changes, such as ensuring equitable access to all evidence-based treatment options for obesity. So with that, I'm going to turn it over. My time is definitely up, I will turn it over to Jeff.